So with severe TBI, or severe traumatic brain injury, there are two fairly common lesions, and one is referred to as a contusion or a bruise, and the other one is referred to as diffuse axonal injury, or DAI. A contusion is essentially a bruise on the brain from the brain being the sudden acceleration and deceleration of the brain within the skull. The brain will bounce forward and back and side to side also. And so the most common places for these bruises or contusions are in the front of the brain, the back of the brain, so the occipital region and the frontal region, as well as the sides or the bilateral temporal lobe regions. And those are the most common places for these contusions to occur in a motor vehicle crash, for example. The other most common type of lesion, DAI, or diffuse axonal injury, when the brain is bouncing back and forth, it's not just getting bruised. All the neurons have long axons that connect each other, so our neurons communicate via axons. The axons will get sheared, torqued, and twisted. And torqued and twisting is the more common than shearing. You don't often see a complete cutting of an axon. You see more of the shearing and twisting, and so therefore it really can't perform its job or its function like it used to. So it may still function a little bit and send a message to another neuron, or it may not function at all, or it may send an unusual message because it's not functioning properly. So, and this DAI damage is throughout the whole brain as well as the brain stem with severe TBI. Mild TBI is often referred to as concussion. Some people think of it having their bell rung. It can lead to contusions and bruising on the brain as well as DAI. The challenge with mild TBI is that the lesions are so much smaller than severe TBI that we really have not successfully detected them on images. There's research going on right now to try to understand the actual lesion pathology that occurs with mild TBI. Most of us presume that it's there and we just haven't found it yet, but there is also some preliminary evidence to indicate that there are a lot of microlesions that occur with mild TBI. The symptoms with mild TBI are going to occur usually immediately within a few hours, and they will last, a couple days, a couple weeks, and for most people the symptoms will resolve after 3 months in a civilian mild TBI. But then there's a proportion of people, about approximately 10% will have persisting symptoms that don't naturally go away or repair or resolve. And those are the people who we're trying to understand a little bit better as well. What is it about their brain that is different than the person who incurred this and the symptoms did resolve? Now with our military, the mild TBI is different because the soldier, the warrior, is there in the combat zone to do a job, and he may not be paying attention to the symptoms that could be occurring immediately. They could have a headache, and they could attribute that to tension or the fact that they've had a gun going off in their ear for a couple hours. So they're paying attention to other things that we need them to pay attention to, such as, keeping their buddies out of harm's way, protecting their flank. But often these symptoms are getting reported after they return stateside. Here is a normal, healthy brain, and here is a person with a mild TBI. And at first glance, you really can't see any difference, but yet they have these symptoms. And so the lesions are there, and our job as researchers is to figure out how do we measure and how do we describe the profile of a mild TBI brain. So here's this nice, healthy brain, and one point to look at is these ventricles. And then here's someone who's in a minimally conscious state or has incurred a severe TBI. And one of the hallmarks of severe TBI is these huge or enlarged ventricles. And here's a classic example of a subdural hematoma right here by that red arrow. Okay, so you can see that that's how it will show up on a scan, is this sort of white oval area. And you can see how that collection of blood is pushing on the brain. Now here's someone who was in a motorcycle accident, and he had to have part of his frontal lobe removed in order to help him survive. Here was someone with a severe TBI that didn't have to have their frontal lobe removed, but here's someone who did have to have their frontal lobe removed. So obviously very different lesion patterns that we're working with. So someone who incurs a acute severe traumatic brain injury is going to go into a coma. And a coma, again, is when they are in a state of, they're really not able to be aroused, their eyes are not open, they don't respond to noxious stimuli, they're unresponsive typically in a coma. Now, that will evolve at some point. Typically within 2 to 3 weeks, they'll start to open their eyes. But they're opening their eyes, but where are they is the question. They have a they have a sleep-wake cycle, for example, but they're not aware of their environment around them typically. They're not able to engage their environment. When people try to get them to engage, they're also not necessarily responsive within a contextual manner. So, for example, they may jerk their leg out, but that's certainly not a response you would expect. So this is what's referred to as a vegetative state. And it can evolve into a vegetative state, or someone could go very fast, and they could go from coma back to full consciousness. Certainly that's a much better prognosis than someone who goes slower along this continuum. They could have something that's called locked-in syndrome, which is different than vegetative state, and then they could also ultimately pass away. Okay, so some patients then who go from the vegetative state will progress to something called the minimally conscious state, and that's where you walk into the patient's room and you think, oh, I know he answered that question for me. I know that he was aware of me and tracked me and focused on me and followed a command, but then you can't get him to repeat it maybe the next day. So they're showing this minimal set of behaviors that are reflective of consciousness, but it's not functional. You can't get them to, you can't rely on the patient to express their need. Then they may evolve into the recovery of full consciousness after that. People can languish in these states, and of course, that is not a state anyone would want their loved one to live in. And then people who recover full consciousness, though, both can have cognitive and physical impairments. Both can have chronic deficits. And right now, while we don't have treatment options that we know are effective for this patient population, we are working on it, and we are working to develop those treatments. So there are researchers such as me out there trying to develop treatments that effectively improve function as well as accelerate that recovery.